Good evening, everyone who's present this evening. My name is Kathy Harley, and I'm speaking to you from the unceded territory of the Algonquin and Anishinaabe people in Ottawa, Ontario. Please add where you're from into the chat box at the bottom of your screen. It would be nice to know where all of you are from and get us all connected together. As the CEO of NSWOC Canada, we welcome you to this continuing education webinar, Moisture Management, What's New and What's Next, with our special guest speaker, Dr. Mikel Gray. For those of you who haven't had the privilege of attending a lecture given by Dr. Gray, you're in for an engaging and fulfilling learning experience. And before I formally introduce Dr. Gray, we would like to thank Medline, and we have Shelley Mazalik on with us this evening, for supporting bringing this webinar and continuing education to all of you this evening. For those of you who have questions, please gather them throughout the presentation, and there's a Q&A box at the bottom of the screen. And we would appreciate it if you would add the questions into the Q&A box so we don't miss any of them. And then at the end of the lecture, we'll have a facilitated question and answer discussion. And now it gives me great pleasure to introduce our guest speaker, Dr. Mikel Gray. Dr. Gray is a nurse practitioner and a professor in the Department of Urology and School of Nursing at the University of Virginia in Charlottesville. He earned a master's degree as a pediatric nurse practitioner from the University of Virginia in 1981 and certificate as a family nurse practitioner in 2000. He earned a PhD in lower urinary tract physiology from the University of Florida in 1990. Dr. Gray is licensed as a family and pediatric nurse practitioner and holds additional certification as a urologic nurse practitioner. He is editor-in-chief of the Journal of Wound, Ostomy, and Continence Nursing and a board member of the Society Center for Clinical Investigation. He has lectured both nationally and internationally on topics related to urologic nursing, wound, ostomy, and continence nursing, and evidence-based practice. A fellow in the American Academy of Nursing, Dr. Gray is past president of both the Society of Urologic Nurses, Associates, and Certification Board for Urologic Nurses and Associates. I would now like to turn things over to Dr. Mikel Gray.
Thank you, Kathy. And I also wish to extend my thanks to Medline and to Shelley in particular for allowing us to do this webinar. I'm delighted to speak to you tonight. I want to talk about moisture management, and I'm going to try to address what's new and what's next. You know, you might think, okay, it's the continence guy. Why is he addressing moisture management? And really, I think this is one of those very rich and very worthwhile crossovers in all of our practice, whether in wound, ostomy, continence, full scope, however you want to call it. This is one of those lovely crossover areas where we really talk about how does moisture interact with the skin, what is its impact on the skin, how do we deal with moisture? I want to go beyond simply incontinence, urinary fecal incontinence. We're going to talk about microclimate. We're going to talk about intrinsic moisture, such as perspiration. And let's pull it all together and see what we hold in common. Alrighty. In case you're wondering, the man is desperately trying to get his computer to move forward. And so I'm going to escape for just a moment and see if I can get that to work. There we go. I was paid, I am being paid, I should say, an honorarium from Medline for this presentation tonight. I'm delighted, appreciate that. The objectives want to talk about moisture management. And really, when we talk about moisture management, this definition I'm going to give you and share with you does come with a focus on pressure injury prevention. It comes directly out of wound care. We're going to talk about the foundations, that is absorption, containment, diversion, a newer area suction, to a lesser extent, wicking and enhancing the microclimate. And we're going to talk about various strategies for doing this, including the old-fashioned proven interventions of structured skin care strategies, enhancing the microclimate, incontinence management, of the bowel and the bladder, including diversion when necessary. And I'm not talking about just surgical diversion. So I was asked to do this talk originally for the WOCN, and this is an evolved version of that talk. And Lori McNichol was one who particularly came to me and she said, we want you to talk about moisture management. I said, well, that's really a wound care topic. She said, that's absolutely right. And I want you to approach it just as that, as a wound care topic. So I started out with a literature review. I looked at Medline and Cinol and PubMed. We went from 90 to 2024, and I used the word moisture management. And I also used pressure injury, pressure ulcer. Paradoxically, I found only 13 unique citations. So it's largely talked about among wound care specialists, but the literature and the research base is really continuing to grow. I included the term moisture management in the article title. And if you look at that, only 1 in 13, 18% actually talked about it. The others talked about it in the back. There was also probably most talk about really incontinence management being a part of moisture management. So when we talk about the definitions, again, the term comes from, the best I can tell, from the NDNQI, which is a national database for nursing quality indicators. That's out of the States. And they have a survey that identifies pressure injury or pressure ulcer prevention practices that are related to skin moisture and talk about incontinence management strategies. They also bring in strategies used to manage microclimate and then moisture from other sources such as draining wounds. And it really is a unique term. It is part of the larger vocabulary for wound care, WOC nurses. And though I don't spend a lot of time speaking to them, I have spoken to the tissue viability nurses in the United Kingdom, and they also use this concept of moisture management. As a matter of fact, one of the precursors, moisture lesions, comes out of the EPUAP and the European tradition. You think of Tom DeFleur, and more recently, of course, Dimitri Beekman. And what we're going to talk about is skin care, support surface selection, selection of specialty linens or coverlets, topical dressing, and particular incontinence products, what they do to not only incontinence, but also the local microclimate. So let's talk about moisture management and incontinence. Again, when we talk about that, what we talk about in my world, that is the continence specialty practice world, are bladder management strategies as compared to incontinence management strategies. So bladder management strategies are what we use to enhance lower urinary tract function, essentially filling and storage function. And then we want to talk about bowel management strategy. And this is what we use to ensure adequate storage and evacuation of fecal matter or stool from the bowel. So when we talk about incontinence management strategies, we're really talking about absorbing, containing, collecting urine or stool in patients with urinary fecal incontinence. And again, if you look at wound care nurses, when I talk about incontinence management, my colleagues tell me, well, that's moisture management. When I talk about support surface selection, they tell me that includes microclimate management, that includes moisture management. So you can see how this all comes together, and it's not really unique to continence. It's not unique to wounds. It's really a lovely combination of both of those approaches. So let's start out with the microclimate. You know, it's interesting. If you look back at the history of climate management in hospital care, you can go back to the 40s, immediately post-World War II, and you had patients who were dying of fevers. One of the developments from engineers, as well as other people in Florida, obviously our most humid and, well, among our most humid, I should say, states, was this idea that if you can drop temperature, if you can condition the air, drop temperature, drop humidity, it actually can be a positive intervention for preventing death in individuals who are running high fevers, because you're going to the early days of antimicrobials where fever was not as tightly managed as it was. And now we're down to microclimate. So basically we're down to a several centimeter, as you can see, rather small layer of calm air that lies between your patient's skin surface and the laminar airflow in the surrounding ambient room. And of course, the two elements that most directly that influence essentially, we'll say, vulnerability to pressure injury and to incontinence-associated dermatitis. That's the IAD in the parentheses. Is going to be what is the temperature of that air and what is the humidity of that air. It varies quite significantly. You know this as well as I do. You've sometimes been bundled up at night, and it can be that little cuddle puddle, as some of my folks used to call it, where the dog is on one end, the kids are on the other end, and everybody's in the middle, fighting for space and all this kind of stuff. And you realize that, this arm is rather cool and that arm's rather hot. My tummy's rather hot because one of the kids is laying on top of me, and so on and so on and so forth. So we're talking about variability in this microclimate. It's up to 6 to 7 degrees Fahrenheit. And of course, the temperatures can measure as much as at the skin will measure up as 50 degrees during extreme circumstances such as fever. So when we're talking about microclimate, we're talking about just a few centimeters between your patient's skin and whatever is above or below that, including support surfaces, coverlets, dressings, medical devices, etc. Now, when we want to reduce temperature and humidity in the microclimate, and that's what we're largely trying to do. It's by far the most common thing we're trying to do, though we will talk about perhaps enhancing moisture in some limited cases. We want to look at specific interventions. And the first thing, of course, we can do is we can manipulate the ambient conditions within the patient's room. So you'll consider the temperature, the ambient humidity, and the airflow. Obviously, by increasing airflow in general, we will reduce the temperature and the humidity in that microclimate next to the skin, provided there is some communication. By increasing or decreasing things like ambient humidity in the patient's room, again, in the United States, particularly in the more southern United States, where I grew up and did my doctorate as one example, state of Florida, we're talking about generally getting cooler air with less humidity. But if you live in a very, very cool region, particularly in the winter months, you may be talking about getting warmer air with increased humidity. So that can vary depending on the patient's need. We need to be minimizing inclusion of the skin, and that is to say, minimizing layers, paying close attention to topical dressings, paying close attention to incontinence management. Not only what are we putting underneath the patient to manage incontinence if the patient is indeed incontinent, or what are we putting underneath all of our patients? Are we putting pads that are meant for incontinent patients under every patient as a matter of routine? When indicated, we want to select products that enhance airflow. So we want to talk about support surface selection, breathable and adhesive tape backings, body-worn absorbent products with a breathable feature. We'll talk about some more of these, and specific external collection devices. And finally, we also want to look at topical skin protectants that avoid maceration. Do we need to use a cream-based or an ointment-based skin protectant? Can we use something that is a little bit less, that's a little bit more breathable, that allows a little bit more of water vapor transfer, perhaps a silicone on one end if we're still in the cream and ointment, or something like a cyanoacrylate or some sort of a polymer acrylate skin protectant on the other end. So let's start out with a structured skin care regimen. Now, this is the thing that we started with. It's evolved a little bit, and it is cleanse. There's no doubt about that. We need to get irritants off the skin. We do not want the skin in contact with things like liquid stool, whose pH can be as high as 8 or 9. That alone will inflame the skin without any of those digestive enzymes or anything else in urine or stool. We need to protect. That includes removing irritants, preventing irritants, and also, when necessary, using leave-on products. I gave you two big classes, ointments, creams. I'll put those in a single class in a moment. Leave-on topicals versus the cyanoacrylates or the polymer acrylates, which would be leave-on product as well. And then we're still just scratching the surface, but we want to enhance the moisture barrier without simply creating hyperhydration of the skin. In terms of cleansing, we have some principles that we can lay down, and I'll gladly share those with you. If you look at the top figure on this particular slide, these are a group of elephants who are greatly enjoyed being scrubbed down, and they're using very, very rough scrub brushes and these types of things on them. but is simplified in the two illustrations that are looking at not quite microscopic views, but essentially quite enhanced views. And you're looking at the classic hospital washcloth with its, very chaotic linen design. It creates a lot of friction at the skin, versus on the right, a more disposable washcloth. So what you want to do is you want to talk about cleansing after every episode of incontinence. With fecal incontinence, you need to be more prompt than with urinary incontinence. But again, if you look at some of the research here, I've used some more review articles down here, but nevertheless, if you look at some stuff, for example, that Leanne Phipps and Evan Call and I did, where we talk about changes in the skin with exposure to a synthetic urine, in this case, in healthy volunteers, within as little as 2 hours. So we are talking about minutes to a couple of hours, not hours to a shift. Gentle cleansing, consider no rinse skin cleansers, minimize towel drying, consider the type of washcloths which we've already discussed. And again, products that minimize potential irritants. I realize that there's a marketing term that's called pH balance, but I really want you to just be looking at, is that skin cleanser close to the acid mantle of the skin? In other words, not that that's the acid mantle. We know that it's in the lower range, the 5 or 6 range, but we wanted something between about 4 and a 7, and not the more cake soaps as one example that tend to run 8 and 8 plus. We want to avoid massage. This is something I don't see a lot in the United States, but I was in Taiwan, I was in rural China, and I've been in multiple other areas of the world, rural Africa as well. And really, this is from the NPIP, EPOAP. So thrilled to hear, by the way, about the Canadian Pressure Injury Advisory Panel. If I have that wrong, this Pressure Ulcer Advisory Panel, good for you. Regardless, I'm delighted you're really getting active in that. But these global guidelines, they specifically advise against the massaging of the skin. And it really just increases the risk for local tissue inflammation or damage. And again, I don't see it a lot in Canada, I don't see a lot in the States, but I do see it. It's still a pretty prevalent global intervention. We want to select the skin protectant. It should be a moisture barrier, but it has to also maintain hydration. It needs to be favorable to the skin's normal tool, the transepidermal water loss, water vapor transfer, so on and so forth. It has to avoid maceration. And you have, again, 2 basic things. You've got ointments, you've got creams, and the reason we bring out zinc oxide is because when you put traditional zinc oxide into an ointment or a cream, you get something that's called a paste. It tends to be a little bit more almost tactily gritty, and it can be, of course, smoothed out, but it's not quite an ointment. It's not quite a cream. So they tend to call it a paste when you put that zinc oxide in it. The alternative to that would be the polymer acrylates or the cyanoacrylate skin-based protectants. Now then, in terms of the skin protectants, you've got petrolatum, which is going to be petroleum jelly. It's a byproduct of oil production, to put it simply. You've got dimethicone, which is derived from silica. It's a silicone-based oil, or formulated as a silicone-based oil. I will tell you that there's lots of variability in the quality of these various products. I'm not going to get into individual products. My job is going to be CE. I'll leave everyone else. I'll leave other folks their job is about selling individual products. And finally, zinc oxide. And again, it does tend to be a white powder. It tends to be called a paste rather than an ointment or a cream base. Cream base, of course, have a water base with a measurable pH that you want to be close to skin pH. Ointments are oil-based, and there is no measurable pH in those products. Petrolatum gives strong protection against irritants. It generally avoids, or it's minimal maceration of the underlying skin, and it has modest skin hydration. That is the ability of tool or a water vapor to transfer across the skin. Dimethicone, I've already talked about and made an argument regarding quality in this area. It has variable protection, some modest protection, some quite significant protection. It has modest protection against maceration, has to do with a lot of factors, and it has excellent ability to allow tool and water vapor transfer. Zinc oxide is the strongest protection against irritants. There's no doubt it wins hands down, but it has less attractive features when you're talking about the potential for maceration of underlying skin and poor skin hydration. The oxide paste also have another couple of challenges that are attached to them. One is that a lot of clinicians, wound care 101, you already know how to do this, but a lot of clinicians don't understand how to remove a zinc oxide paste. And teaching staff nurses and caregivers, non-professional caregivers, family members, etc., how to remove a zinc oxide appropriately can be very helpful. The acrylates and the cyanoacrylates, again, there are several potential advantages. There was a randomized controlled trial in 1981. It was skilled nursing facility residents in 16 of the United States. They looked at 2 ointment-based and 1 cream-based skin protectants that were applied after incontinent episodes and at least daily. They compared that to a terpolymer acrylate that it was applied 3 times weekly, and they found no differences in the efficacy of any of those skin protectants on treatment of incontinence-associated dermatitis. More to the point, a study of 16 patients with IAD found that 81% show improvement within a period of 3 weeks despite ongoing incontinence, and only 2 of those patients, 15%, actually deteriorated. So again, there's some evidence that these products not only have some positive things compared to ointments, allowing they have excellent skin hydration characteristics. They have excellent avoidance of maceration. So there's also some advantages here. There's some cost advantages. We haven't explored that quite well yet. There is some evidence concerning the polymer acrylates or the cyanoacrylates for pressure injuries. It does remain limited. I think one of the big areas, which is one of your big areas of growth where you're really beginning to look at and be more assertive and aggressive and looking at acrylates and cyanoacrylates for pressure injuries. And in this case, there's been at least some laboratory and some model-based studies that are really beginning to show that careful application of cyanoacrylates under certain medical devices, such as those that in breathing apparatuses, trach and so on and so forth, things around the facial area, the nasal area, so on and so forth, has a possible role in preventing these medical device-related pressure injuries. The research looks good, but what we need is some more robust clinical level research. So that's not only a call for such research, but it's urging you to move along with that. Now, it has been looked at in neonates. So the first thing I want to say is I'm not going to show you any studies, and to my knowledge, none exist, that show that use of a cyanoacrylate or polymer acrylate is actively harmful in infants. So that's the first thing. I'm not trying to rule it out. This is Vida Boyar's study along with her colleague Desai. She's a neonatologist in the northeastern United States. And she looked at 33 neonates, and you can see that they were 23 and 32 weeks of gestational age. They applied a liquid polymer acrylate to the left chest, left abdomen, and left anterior posterior upper thigh. Right side was left untreated, and it was applied every other day for a period of 2 weeks. They looked at cutaneous pH, hydration, all these hydration things. I won't go through them all. They also looked at a neonatal skin condition score. And what they found was that particularly the skin condition score indicated drier skin and greater superficial breakdown, lower hydration values at days 7 and 14, and a little bit higher tool, which meant that there was a little bit of a compromise to that. Cutaneous pH, no statistical significance. So what they're saying not is that these polymer acrylates are harmful. What they're saying is that you need to limit it to application underneath these high-risk skin areas, such as underneath medical devices, underneath dressings, PIC dressings, and all kinds of dressings that we might use on acute and critically ill neonates and infants, and underneath medical tapes. So this article is not saying don't use it, it's saying use it with caution in neonates. Louise, I know, and her partners, they really did some lovely stuff with ostomy care, for example, in this, and I expect they'll be having a look at wound care And this could be some really helpful research in that area. If you want to enhance that moisturization, this concept of moisturization really is it comes from the cosmetics industry. It's not out of medical care, but it's broadly defined as using products to increase the moisture in the stratum corneum. I will tell you that evidence related to moisturization pressure injuries is mixed. I'm bringing that right out of the 2019 guidelines. And they basically tend to be similar to the IAD guidance in recommending a focus on cleansing and protecting with general support for moisturization. Certainly, I think that the idea of using some sort of humectant, which just attracts moisture to the area, probably less attractive than using some sort of emollient. And in general cases, this is generally added to either a cleansing product or something like a pre-moistened cleansing cloth that has multiple roles for cleansing the skin and for applying usually a silicone-based skin protectant. So let's talk about support surfaces and related technology. I think one of the big things here is we're now looking pretty exclusively at the microclimate. So we already know that the cutaneous microclimate, again, this is straight out of the guidelines. It's really, and what they say, it's an indirect risk factor for pressure injury occurrences. Basically, all of those guidelines, again, if I look back at some of the CAT and now INSWAC, WOCN Society recommendations, they basically say we don't know enough to make strong recommendations, but they do ask you, look at the potential impact of moisture on the risk for pressure injuries. Consider the impact for increased body temperature on the risk of pressure injuries. I remind you, and this is straight out of my colleague, Laura Edsberg. Dr. Edsberg is a brilliant researcher and former NPIP president. And she's shown that there really is a very significant metabolic course for every increased degree of temperature at the skin surface. So if it's getting humid and it's getting hot in that little microclimate, that is creating a greater metabolic demand. That is creating greater skin flow demands and a greater risk, we would think, based on clinical principle for pressure injury. The WOCN support service algorithm, which is open to all individuals, whether you're a member of the WOCN Society or not, I think is very critical. And by the way, this was led by Lori McNichol. And basically, they incorporate skin moisture assessment when evaluating PI risk. We tend to use the Braden scale for pressure sore risk. There are multiple pressure injury or pressure sore is the original name. Pressure sore is an older word, but pressure ulcer, pressure injury. Risk assessments, they all look at moisture and or incontinence, a component of moisture. And but using the Braden scale, basically what they said was use the moisture subscale as an independent indicator of moisture. And they said that patients who had these lower scores indicating greater microclimate, greater risk of moisture, should be placed on support surfaces with alternating pressure and low air loss features, which of course, again, has a little bit of, it improves airflow, reduces temperature and humidity in that all important microclimate, particularly the lower microclimate, as is somewhat illustrated in the figure above, between your patient's skin surface and the top of that moisture barrier. They also noted that patients with full thickness pressure injuries, stage 3 and 4 pressure injuries using the NPIP 2016 updated system and a Braden moisture subscale of 1 or 2 should be placed on either alternating pressure mattresses with low air loss features or air fluidized surfaces, or as you know, they now have combination where they've got a little bit of air fluidized in one area of the bed and then an alternating pressure with low air loss in another area of the bed. I think these are some really interesting and innovative ways to look at support surfaces, and you want to be the person that's incorporating moisture management with your overall use of support surfaces. In terms of, again, there are some other things that we looked at. There was a powered coverlet we looked at. It was evaluated for its ability to reduce temperature, humidity, bacterial load at the skin surface. It was a 3-tiered device that had some vapor permeable, some liquid impermeable layers. It's interesting, and basically, again, what they looked at, that it tended to draw moisture and heat away from the skin. Again, getting that down through this little spacer that they had built into the design. They reported results. This is out of Rieger, and I believe it's Reganathan, and if I mispronounce that, my deepest apologies. But they looked at a trial that used essentially in vitro trial, and they did find that it did the things that it was supposed to do when compared to a standardized hospital bed sheet. So there are things that are being developed. Unfortunately, most of them have not yet gained very widespread clinical usage. I do think they're worthwhile looking at. You want to watch as these technologies evolve. Again, textiles with low friction coefficients. So I'm going to go right back to my colleague, Lori Mikel, who really worked with a group out of North Carolina in the United States, one of the southeastern United States. And they really found B1 evidence based on findings from 6 studies that these things, they reduce friction, they reduce moisture. They do have positioning sheets that can be used for patient transfers, and they have positive impact when looking at pressure injury, pressure ulcer prevention. I found one article that looked at the effects of a 3-layer disposable sheet. It was air permeable layer, absorbent inner layer, and a breathable waterproof bracking layer. And it was really designed for birthing beds. Now, I'm bringing it out just because it did talk about moisture management. It's obviously used in a very limited group. Women found that they were great. Their comfort was highest when they use absorbent sheet and a feminine hygiene pad. That's a very specific recommendation of that very specific research. Why did I bring it out? Because it just reminds me to say to you that even when you're using some of these support services, there still is a need for limited use of other things to manage incontinence as that specific moisture use, just as you would manage a suppurative wound with high exudate levels with specific dressing. So this is meant to be overall management. It does not replace what you're doing on areas of wound, patients with urinary or fecal incontinence. Again, the application to our specialty practice, such as patients with an ansarca or very diaphoretic patients, is uncertain, but it's a possible crossover that can be looked at. I'm not going to talk to you much about this. You are the experts much more than I, but there are preventive dressings that enhance microclimate. One, for example, that's illustrated here uses silicone multi-layered foam dressing. Again, the idea is that you want to be able to do daily assessment, and they're now developing this sort of thing that tends to be clear so that you can easily do that. The dressing size, it's variable. You need that to really target your areas of protection. And then this idea of this newest dressing, again, I go back to about these protective dressings, and they really have strong research supporting the one that's illustrated on the right of this particular slide. It allows for ongoing visible inspection. I think that's very important. There is some initial experience. It's not yet evidence that suggests longer wear time, up to 7 days. There's also some initial, I'm going to say, suggestive research, must be peer-reviewed, must be published, must be brought forward in a more formal manner, that suggests that the average local skin temperature is up to 1.5 degrees centigrade cooler. That does reduce the risk for moisture-associated skin damage. And there is at least indirect evidence that also reduces pressure injury risk. This is worth looking at. Additional research needs to be done. I strongly encourage you to look at this product, to evaluate it, to publish your findings. Additional research must be done. Microclimate in the heel, everything changes. I've taught you about moisture, 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 over moist, over moist, over moist, over moist. Now I'm going to pair that all up and I'm going to talk to you about the dry heel. The idea about microclimate at the heel is that it's not typically affected by a warm, humid microclimate. It tends to be cooler. It tends to be less humid. As a matter of fact, it tends to really the local conditions plus, some of the things, because you're talking about essentially a sort of a top-down, effect with this drier cooler humidity that leads to a drier and stiffer epidermis, along with an increased risk for mechanical damage. So you start out with scaling and cracking and fissures and inflammation. I'm sorry, but I love to look at baby feet because they're so lovely and unused. So when I look at my feet, they're neither lovely, and I promise you, after 67 years, my feet are magnificently used. So the idea is that we want to do interventions, preventive interventions that may actually look at some of that lack of moisture at the level of the horny level of the skin, along the heel itself. And we want to notice that if you look at this one example, this is from Lechner and colleagues, when they had 79 versus 42% of heels with stage 2 or higher pressure injuries had dry skin. Okay, so again, we're not quite sure because the odds ratio did cross the 1. So we're not quite sure about the magnitude of this risk, but we need to start looking at heels as a more unique. And you know this when you take care of these patients. It's a bit of a unique area of the skin, and it's something that needs further research. But I do think that the microclimate at the heel is probably one key area that needs additional research and where additional preventive interventions can be designed and implemented. Again, what do we have in our current guidelines? Prophylactic dressings. I think that's great. It's an adjunct to heel offloading. You certainly want to offload those heels using whatever you're talking about. It's about a B1. I'm talking more about, moisture management, how that sort of comes into it. And these prophylactic dressings do have positive. And you saw, data from, for example, one of these new innovative type dressings that I just presented. But all of these preventive dressings, all of them, I want to emphasize again, all of them have solid evidence. The ones that have been on the market have solid evidence that they are at least reasonably effective in preventing pressure injuries, and that they do offer moisture enhancing properties as compared to no dressing, at least compared to no dressing. So is this a situation where we need to enhance the moisture barrier? If we're going to do that, I can say 3 things. Emollients or lipids that designed to smooth the skin surface, and you can use lanolin, glycerol. There are a whole lot of other things. Ceramides is the one that's getting the most talk right now. Why ceramides? Because it is the number one. It's a 3 to 2 to 1 ratio of fats in the skin, in normal skin, and ceramides is a big one. So there's limited evidence that suggests that these ceramide-based moisturizers may be good. Humectants may be good. We just don't know enough to make solid recommendations. What about incontinence management? Well, obviously, woundostomy incontinence practice remains a little bit uncertain. The statement in these slides are going to be my opinion. I have practiced for 44 years as a continence nurse. That CCCN-AP that you saw is my practice, and that certification through the WOCNCB is an advanced practice continence care nurse. I've been practicing 25 years as a WOCNF faculty, and I am editor-in-chief of your journal, and it's not my journal, it's your journal, and I've been your lifelong cheerleader. So here's what I'm going to tell you that I think where we're at. Number 1, I think that you need to be identifying incontinence, fecal versus urinary versus dual incontinence. I think you need to differentiate those incontinence zones in your wound care practice because they have a differential impact upon the risk. I think you need to look at what is light versus heavy urinary incontinence. Light episodes tend to occur less frequently, up to 100 mLs. Heavy episodes are great big involuntary voids. And you need to be able to differentiate roughly how often is this patient having bowel movements. Is it liquid versus semi-liquid versus liquid stool? And you know that the risk levels, the metabolic activity of those enzymes is going to go up with that. And finally, you need to understand that's what's happening to your patient. I'm really speaking to my inpatient colleagues right now. What happens with nocturia? Nocturia is a separate disease as well as a lower urinary tract symptom. It is a distinct etiology. It is nighttime urine production, goes up with aging. Small increased physiologic, large increase in multiple comorbid conditions. Bladder capacity, it does not go down with age, but there are greater diseases associated with overactive bladder that does drag it down. And finally, sleep quality. And we need to look at all three of those together, and we need to talk about keeping our patients in bed and protected at night when they're acute or well, particularly acutely ill, certainly critically ill, and not ventilated. So the first thing we always start out with is independent versus assisted toileting. If your patient can toilet, they should toilet. They don't have to be entirely continent to toilet. There is no reason that we cannot manage particularly light incontinence or occasional incontinent episodes. We want to provide assisted or scheduled toileting every 2 hours is the general idea, just like we provide turning and repositioning, and you can adjust that as indicated. We don't want to be getting these patients up all night long. We want to try to avoid things and to routinely protect them. I'm going to talk about some of these suction collection devices, and they're really making a positive impact in there. And just remember, in absence of incontinence is not an essential goal. We do that. We want to teach about, of course, independent toiling. We want to give them the correct sitting position. I literally walked in and they said, we don't understand. She's not passing her voiding trial. I walked into the room today. These are urologic clinicians. And I walked in the room and I said, well, first thing we're going to do, Ms. Gray, my patient Troy and Ms. Gray, is put a couple little stools under there as is illustrated in here. We walked out of the room and she managed to pass her voiding trial with flying colors. Position, leaning forward. This is not only for defecation. This is from Jonas Staskowitz's work in one of her figures that she published in JWalk in your journal. And we want to talk about defecation and bowel management regimens. As close as they can get is what they did. And we want to be very aggressive and assertive with these. We want to be equally assertive with incontinence management. If it is greater than or equal to 3 unformed or liquid stools a day, the risk for IAD, the secondary risk for pressure injury, goes up dramatically. Because of enzymes, they become metabolically active. The pH range of the stool and other issues is going to create those problems. There's also a very potent bioburden and biome with coliform bacteria and microorganisms. When they get out onto the skin and they start replacing the normal flora, the skin integrity becomes critically endangered. And we see this over and over and over again in our clinical practice. So we want to start out with assisted toileting. We want to talk to physical therapy and occupational therapy. We want to get the devices out that assist with mobility. We want to get out the urinals. I will tell you, I'm very jealous of those of my colleagues in Canada. The United States has about 7 or 8 effective urinal devices. And when I go to your meetings, you're talking about a dozen or more. And really that variety is absolutely essential. One size never fits all. We want to use these bedside toilets whenever necessary. We certainly want to use high absorbency incontinence products to protect the skin. Individuals who are at risk for pressure injuries and have incontinence. This is directly out of the 2019 guidelines. They're going to say underpads is a first line management strategy. I'm not going to have any problem with that. It needs to be carefully selected underpads and not simply the cheaper blue pads that we tend to use in examination areas or clinics or something like that. They certainly may be used in conjunction with indwelling fecal drainage devices and indwelling urinary catheters. They should only be used on patients with incontinence. They should not be used on continence patients to protect the linen. These are the features we're going to look at. We want to look at some sort of a non-woven top sheet that allows moisture to get in really quick. The absorbent core should have a super absorbent. That is a single word, and there is no really other word for that. It is some sort of a branded name, though I can't figure out. There's no real company that I can find associated with it. But nevertheless, the super absorbent blows up to about 31 times its size, and it is proven better than simply fluff pulp, which is the old traditional thing that we used to use. And you want it to have a breathable back sheet. Again, protect that moisture management. If the patient is absolutely diaphoretic on top of a water impermeable device and they're not doing a good job. You want to use in body-worn absorbent products. The diaper-free hospital, I hope, is dead. Body-worn absorbent products play a role in critical care. They play a role in acute care. They are not a substitute for underpads. They are not a substitute for any other devices, but they do play a role in the larger armamentarium that you should be using as a WOC nurse in these areas. They play a role in your home care patient. They play a role in your ambulatory patient. Again, it's the same basic thing that we're looking for before. I won't go through this just because of time. I won't have time for questions. But I know that you know this. You need something with a low coefficient of friction. Again, that acquisition layer, super absorbent, enhanced absorbent core, and moisture dissemination through the pad as quickly as humanly possible. You don't want to use these underpads as transfer devices unless they've been designed for that. You do not want to use plastic back products. You want to have breathability, and you want to be careful. If you put ointments down, particularly some of the pastier ointments, some of the paste things, or some of these cream-based products that tend to be put on in very heavy layers, that can vary dramatically, at least in a few studies. The research is still a bit up in the air. Nevertheless, it can impair the moisture absorbent capabilities of these incontinence products. Again, you want to consider an underpad with a brief or some sort of electronic alert system. The newer systems use lighting rather than noise or beepers, which is very good, but it will get you to that patient in time where you don't get in there. I'm going to call on every manufacturer, and that includes a sponsoring manufacturer, to start looking at these devices and start developing the technology. Basis for it already exists that can provide a reasonably good ability to differentiate between whether your patient is having a urinary incontinent episode versus a fecal incontinent episode. Industry partners, it's a challenge, and I give it to you with pride. Finally, when we talk about these underpads use in the context of pressure redistribution, again, consider disposable versus reusable underpads. There's been several studies. I'm quoting you some data here that shows that probably in acute and critical care, we want to pretty exclusively be using disposable, but the reusable do have a greater impact in other care settings, such as home health setting. Always minimize layers. That not only applies to IAD risk, but it also applies to that, again, that straight path from IAD to pressure injury. We looked at a group of patients. This is Sue Kaiser and lots of colleagues, and we looked at a group of patients at about 56,000 and over 700 U.S.-based facilities, and each additional layer of linen on the bed increased the likelihood of IAD by 8.3%. And again, you want to minimize the layers between the patient and the support surface. This is from Mandy Fader, classic UK woundostomy continence. She's really not a WOC nurse by certification, but she is in her heart. She's a wonderful, one of the world's leading continence nurses. And she showed that a body-worn absorbent product used indiscriminately with underpadding and layering, so on and so forth, really increased the tissue interface pressures 20 to 25% on a standard hospital mattress. So you want to be careful in layering and mixing these products without careful consideration. I'm going to encourage you to use the IPCARE model, which is developed by the WOC, and it's available to everyone, whether you're a member or not. It's a nice little electronic algorithm for making some of these decisions. So a couple of things I want to talk to you about in just the closing minute, and that includes the external collection devices. Don't forget these condom type or sheath catheters. Don't forget these non-sheath gland adherence devices. Don't forget your retracted penis pouches. Don't forget these new suction collection devices. I feel very good about these collection devices. In women, they fit between the interlabial folds. They do not fit in the vagina. In males, they tend to have basically a cover sheath around the male genitals. They not only are getting somewhere about 95% of the urine when positioned properly and suction somewhere around -40 millimeters of mercury, positive suction, you want to call it that, that provides a lovely microclimate for overnight incontinence or overnight high urine production. They have really proven popular. My patients really love these devices, particularly for nighttime incontinence. Okay, again, the male devices are brand new, but we do have good initial clinical experience and a growing body, though still modest, of research supporting their use. Don't forget the fecal collection devices. The one at the bottom, I think, is not available in North America, to the best of my knowledge. It uses an irrigation, and there are various products like that. Of course, you can divert using one of the indwelling type catheters that's been used on this slide. That's for urinary, but also these indwelling fecal, stool, and bowel management devices. Here are some references and resources. Thank you so much for your patience with me. I'll take any questions I have.
Okay, thank you so much, Dr. Gray, for that in-depth presentation. A lot of food for thought, some great key messages, and I think we should get right into the questions. First of all, you did touch on it, talking about low air loss surfaces for microclimate management. Could you comment or just highlight any recent research study that's related to incontinence care products interfering with low air loss surface for microclimate management?
You know, it's very interesting because when you look at the literature, it's mixed. So the classic article was Newman and her colleagues. Diane Newman, for those of you who don't know, is a big continence nurse name out of Philadelphia, very qualified friend and colleague of mine. And what they looked at was an ointment base, and we're talking basically a zinc oxide ointment versus paste. I'm gonna call it ointment since they labeled it as such. And it was pretty much spackled on. And of course, it adhered not only to the skin, it adhered to the absorbent product itself. It's a body-worn absorbent product, an absorbent brief, and they showed significant. When you look at other products, they fared much better. So my general thought is, if you're going to have a patient on an underpad, the little research we have, and I don't have a very recent study to quote you, but the little research we have would favor cyanoacrylate, liquid polymer acrylates. It would favor creams that can be, or silicone, for example, based protectants that can put it on in a thin layer, and it will interfere less. The research is controversial. There may be ongoing research, but if there are, I've not been informed of it. So I can't tell you anything's coming down the pipeline right now.
Okay. And staying on the topic of low air loss surface, how does the warming of low air loss surface affect the microclimate?
That's an excellent question. It's all about air movement and airflow. It's not temperature alone, it's temperature plus humidity. How do you get temperature plus humidity in a stagnant, non-flowing air surface? How do you reduce that? Let me ask you a very basic question. I'm from the southern United States. We live humidity. My air conditioning went down recently. How do you sleep in that? I tell you how you sleep in that. Even though the house may be 82 degrees, this is a crude way of phrasing it, you put a fan on. And I could not sleep in 82 degrees of humid, stale, stagnant air. You put a fan on me and I can sleep. It's the same principle in a very simplistic manner that's happening with the low air loss bed. It's about airflow versus the warming effect. Now, I'm not going to argue that there are not differences in products. You know what I'm saying? And if you know product A that has, that's overheating your patient, so to speak, versus product B. But that's the general principle of why it works and why it's recommended.
Okay, thank you. There are two questions here that I'm going to summarize together, and it's around the use of zinc products, which is always a concern, whether you're working in hospital or in the community. The first one was if you could just comment again about the proper way to remove zinc products. And then talk a bit about the best way to teach this to caregivers.
Be delighted to. So there's a couple things about zinc that I think we want to remember. Number one, people want to spackle it on like icing on the birthday cake. Thinner layers of zinc can be useful. If you think about zinc, and I know I should be talking about suntans, but let's talk about microfine zinc versus what I call boulder zinc or coarse zinc. Microfine zinc is the stuff that you get in the sunburn protecting products that you apply it and you think, oh, it's so smooth. It's not like that old terrible zinc oxide that I put on a baby's bum. The reason it's not in all those products that we use is it's expensive. And if you think about it, you're paying a fortune for those anti-sunburn products. So one way forward is to eventually get a way to manufacture microfine zinc. But I got to talk to you in the interim. Thinner layer is fine. Every time a patient is changed, if you can bring off that down to the skin, the zinc oxide does not be removed with every bloody time you touch the skin. It can be put on and it can last. You would obviously get rid of any fecal or other material at the surface, but you don't have to completely bring it off. When you're washing off zinc, people want to use soap, water, and friction. You should remove it with an oil. You know, I was very surprised. I was in Ireland as one example. The Irish, like the British, tend to say, you Americans, you Canadians, you North American folks, you love technology too much. And they literally use safflower oil, not something that I get off my shelves, but they would use that to cleanse off. So you want to use an oil-based cleanser just to bring the zinc oxide off very carefully. So remove the bigger layer of it, and you can use your oil to get it off, and then just use a standard skin cleanser beyond that.
Okay, thank you. One of the another question that came up, there was one of the participants asked if they heard you correctly that you hope that diaperless hospitals are no longer.
I do hope they're no longer, and I know that's a controversial statement. I'll take my black eye right now. Why do I hope that? 24 hours, 7-day a week management with briefs. I won't call them the D word, but with absorbent briefs or pull-on products is definitely not what I'm advocating. Zero advocation for that. But I am advocating that in limited but definite circumstances, that the use of a well-selected body-worn absorbent product, it might be a pad that goes in the underclothing. In women, we tend to call it pads, and men, male guards. It might be a pull-on product. I mean, there are wonderful pull-on products now that did not exist when I got into continence in the 80s. When your patient is off unit, if they have significant incontinence, they may need a brief. They may need a pull-on product. They need that when they have family visiting. When they're in the bed and under the cover and the underpad is doing it, that's appropriate. I'm not saying it's a substitute for underpad. I'm saying that it should be used in highly selected cases. Look at the IP care and you'll see really well-seasoned arguments. My colleague, Dr. Dia Kent, was in charge of that, and she has some really nice arguments about why you should use it in acute or critical care in selected cases with good critical thinking. So
Okay.
thanks for asking that. And I'll take my black eye right now. Boom.
Yeah, no. And then, you know, the other portion of that question was around how does it fit with the fact that body-worn pads can increase one's risk of 20 to 25% with pressure injuries?
And the answer is when your patient is lying in bed, that's not the time to put that brief on. It's when your patient is up for therapy, off the unit, undergoing diagnostic tests, so on and so forth. That's when you use it. It's an excellent question and an excellent consideration.
Okay. Can an external male catheter be used with low suction?
No one has been able to use that successfully because of the physics of evacuating that. The male suction collection devices. And again, I don't want to get into the secret sauce. You know, go to Shelley, some of Shelley's colleagues or other folks' colleagues who can really talk to you about their particular product. But these suction collection devices are designed in such a way that you get a moisture release that you're going to get with any sort of a sheath type, you know, external collection device. But then it is also going to pull that away from the skin in a way that just an old-fashioned condom catheter, to use that term, or even the older term, Texas catheter, cannot do. The physics aren't right.
Okay. And I want to, I'm going to ask one last question because we are at 8 o'clock.
Yes, ma'am.
How do you get your administration to invest in skin prevention versus crisis intervention?
I'm going to be bold enough to tell two stories. I'm going to tell a story that's the bad end of this, of your question. I cannot speak to Canadian system, but I can speak to the US system. And the US system went into the pandemic, and I know I keep coming back to that, but it's such a global event for healthcare. And in my crazy private practice world, you know what I'm saying, that no NHS, no NHI world, for us, we went in with excellent attitude toward that. We came out with reverting back. Too many facilities are reverting back to crisis management. The nurses are burnt out. Healthcare is burnt out. Just go back to crisis management. And now I'm beginning to see it slowly coming back and coming back and coming back. When you talk about the investment and looking at that return on investment with that horrible capitalistic profit margin, you know, eye that we tend to look at it, it gets that dirty squint over short term. But when hospitals look at it and healthcare organizations look at it for long term, they realize that the investment pays off in the long run. And fortunately, our system, as clunky as it is beginning to put in those incentives. We would call them report cards and all these sort of gotcha things. But nevertheless, they're beginning to put that investment in. So argue for the long term, argue for those long-term investments. And really, there's been some good quality, some cost, and some cost analysis research. That's tough stuff. I don't understand it. We publish it gladly. LeBlanc, Dr. LeBlanc, your chief scientific officer, she published a really nice article looking at a particular area of care. Keep going with that research.
Okay, thank you. Well, I can't thank you enough for being here this evening and for sharing your science, your wisdom, research, information, clinical experience. It all makes a difference in how we deliver our care on a day-to-day basis. And I noticed in the participant list, we have people here from big long-term care facilities to home care to hospitals. So I'm sure everybody has taken away something that they can use. So thank you very much, Dr. Gray. We have recorded this and we will be posting it in our webinar library. And that is on the nswoc.ca website. So you will find the webinar there. And for people who were unable to attend this evening, they'll be able to tap into the webinar as well. I'd also like to thank Shelley Mazalik and Medline again for bringing this webinar to us this evening. And Shelley, I saw, has posted some web links where you can get further information on skincare products and continence products. So thank you very much for doing that. Our next online education will be the Canadian Pressure Injury Advisory Panel meeting, which is Monday. It's running all day. It is available virtually. The in-person is completely full. If it has, the web link was emailed to all of the NSWOC members. If you have not received it, you can email office@nswoc.ca and we would be happy to send the web link to you so you can access this virtually. It is free of charge and there'll be great information on pressure injury prevention and management. And so thank you again for your participation and we wish everybody a wonderful rest of the evening. Thank you.
Thank you, Dr. Gray, and thank you, Kathy, for hosting us and for this educational opportunity. Dr. Gray, it's been a real privilege for me to work with you, and I just really appreciate that you accepted this opportunity to speak to our Canadian clinicians, so thank you.
Oh, Lord, I'm honored to have been invited. Thank you. Thank you, everyone. I really hope to see all of you at a meeting, and I hope you participate. I'm sorry, but I'm going to be prejudiced. I want you to participate in that CPI-AP. That's an important meeting. I think it's almost an historic meeting for you all. Get that going. That's wonderful.
Absolutely. Good night, everyone, and thank you.
Good night.